being now virtually with me. So I know it's a different year, but I hope that the talk today will give you a little bit of an idea of what future in pediatrics, but really for any specialty, academic versus private practice will look like. So why don't we start? Give me 1 second here. Okay, so I wanted to talk this morning about when you're a med student thinking about your future, whatever your specialty is, okay? So we're going to do just a quick introduction to me and then talk about how this talk can help you in training. And then we're going to go through a week in private practice and then a week in academic medicine and sort of compare and contrast them a little bit. And then I wanted to tell you now I work at the Children's Hospital of Philadelphia and kind of describe to you what practicing is like pre and post COVID as an attending. And then I'll tell you a little bit about my my new journey into social media. And then we'll pause through the talk, but also at the end for any questions that you have, okay? All right, so just a quick introduction to me. I am Anjuli Gans. I went to Georgetown for my medical training. So I went to Penn before that for my undergrad. And then I actually took 2 years off and I worked in the Senate. And I wanted to really understand sort of what healthcare problems people were facing day to day and how from a public health standpoint, kind of medicine mattered. So I worked for the Senate and I did constituent affairs, which is basically talking with people all throughout the state. I was in New York and that was the state we worked with, and figuring out what healthcare meant to them and what challenges they were having. And I found that it was a really great foundation for me for when I did start my training at Georgetown for med school. It gave me a really different perspective on what patients go through and all of the bureaucracy and all of the challenges involved in healthcare today. And I stayed on. I love Georgetown so much. It was a great experience for me. I had great teachers, so I stayed on there for residency, and then I did a year there as chief resident, focusing a lot more on teaching and administration. And so right out of training, then I went to a practice that was in the suburbs of Washington, D.C., called Capital Area Pediatrics, and I worked there in private practice for about 5 years and loved it. It was really cool, and worked there, and then also at our partner hospital, which was the children's hospital called Inova, and did newborn nursery care as well as some patient care in the hospital. And then I continued to teach at Georgetown and the University of Virginia. And my husband was at that time in the White House administration. And about 4 years ago, we had a change in administration. And so he got a job up here at Penn. And so we came up as a family together, he and me and my kids. And now I work at the Children's Hospital of Philadelphia at a place called the Carabats Pediatric Care Center, which is their largest primary care clinic and teaching clinic. And I work here as an attending and also continue to teach back at Georgetown a little bit virtually, but mostly here at Penn now with the med students here. So that's a little bit about me. And I think that I've had sort of an interesting perspective compared to a lot of people because I've done both private practice and academics now. And so I found so many differences and things that I thought to myself, like, I never would have known this if I was in training. I never would have known what to look for or what things to think about as I'm considering my career. And that's why I love to talk to trainees and to students about this. So here's what I hope this talk will do for you. I hope that it inspires your passion for whatever you're interested in, whether it's research or a specific specialty or patients in a different way or administration. And I hope that it helps you to find ways to channel that passion and to use it and apply it as you go on through your training. So through your rotations, when you're picking residencies, things to think about. And also if you're interested in research, the number of different ways that you can do research now and then. So I want everyone to just take a minute, because this is something that I thought about when I was starting out, but didn't have time to really reflect on it and figure it out. And so this year might be a year with all its craziness for you all to be able to do that. And imagine yourself as a doctor very soon. What do you see? And for me, when I was in medical school, I kind of just grew up imagining myself as like the suburban pediatrician who took care of patients and saw them from the time they were born to the time they were 18 or 19. That was just always my image of it, because truthfully, that's all I had ever seen. So when I went to medical school, it was a bit different because I suddenly saw pediatricians practicing in the hospital and in a totally different way, or in clinics in the hospital. And it was all very new. And so think to yourself about how you imagine yourself and what's important to you about that image. Okay. And kind of keep that in mind as we're going through this talk. I'm going to just move this way. So let's start with private practice, and then I'll take some questions. How's that? So when I worked at Capital Area Pediatrics, that was the private practice I worked in. That was in the suburbs of Washington. It was a very traditional suburban practice, the way you imagine practicing pediatrics when you're like a little kid. It was very upper middle class. It was what we call like a mid-sized practice. So it had probably about 8,000 to 9,000 patients in it on any given year. The patients all mostly, for the most part, had private insurance. We had a small group of people who had public, but mostly private insurance. And there were 8 of us as doctors and nurse practitioners who practiced. And then our staff was about 12 people who covered sort of the front desks. They were the administrators, they got patients signed in, they were the nurses, the medical assistants, and that's sort of what it looked like. So every day we would come in, and that was sort of our team. Okay, so what our days looked like was from every day that I would come in, I had 10 or 20 minutes to see patients. That means for a sick patient, so if you came in and you had a 5-year-old who had a cough and cold, you would get a 10-minute appointment to see me. If you had a 7-year-old and they were doing their checkup for that year, you had 20 minutes to see me. So on any given day from 8 o'clock until 5:30, I would see between 24 and 48 patients a day. If patients were late, we really couldn't see them because we were on a really tight schedule. So we really kind of kept patients to a very strict schedule. If they came a little bit late, we would have exceptions, but really they would then have to reschedule. And we almost never had patients who didn't come. So everyone who made an appointment came. So the bulk of my days, I would go in at 8 a.m. I would have my first patient ready in the room. I would start to see them. And then through the day, I would answer phone calls from all the other patients. So if patients had questions about, a medication dosage, or a kid with a fever, or their son wasn't getting better on the asthma medicine I had prescribed, I would do that sort of in between patients. So like right when I had finished a patient, I would make a quick phone call, and then I would get to my next patient. So I'm going to give you a quick patient example, and then I'm going to give you the same patient because I basically had the similar patients in both settings, and give you a sense of how it worked. So I had a patient who was a 6-month-old patient who the mom noticed had been sort of crossing her eye a little bit, her left eye. And that can happen until a certain point. When babies are newborns, their muscles just take time to develop. But she said, no, it's gotten a lot worse over time. And when I examined her, I looked for a thing called the red reflex, which is, every baby should have it. And I didn't see one. And that to us as pediatricians is concerning for things like congenital cataracts or mass like retinoblastomas, things like that. So I gave her referral to see a pediatric ophthalmologist at Children's Hospital. I called the ophthalmologist, I left a message, and they said they would see them within the week. And so they saw them a week later, and the baby was diagnosed with a retinoblastoma, unfortunately, but fortunately we had caught it very early. And so she got in to see an oncologist at Children's the next week after that, and then underwent treatment and has been doing beautifully since. Okay, so that's kind of like the broad scope of that patient. And then we'll come back to that patient when I talk about academics and how our approach to patients is a little different and the workflow is a little different. And then at the end of the day, I would basically do all the paperwork that I hadn't gotten to do through the day when I was doing phone calls and see patients. So I would fill out school forms, I would fill out pre-authorization for medication, things like that. All right. And so that was like a typical day. And then the practice was a little bit unique, and probably this model won't exist for too much longer. sorry, excuse me about that, won't exist for too much longer. But what we also did was, as part of our private practice, we partnered with the Inova Children's Hospital and admitted our own patients to the newborn nursery there. So basically, if a mom was pregnant, she had a baby, she would deliver at Inova Fairfax. She said, I want Dr. Gans to be my pediatrician. So I would go to the hospital after she delivered, and I'd be the first doctor to see the baby. I would examine them. I would talk with mom and dad, or mom and whoever partner, or just mom, and discuss everything about their follow-up. And then I would discharge them and plan to see them in the office for follow-up. And then if there were one of my patients at the office and they had, let's say, pneumonia that couldn't be treated in the outpatient setting, I would then admit them to the hospital as the attending and work with the residents in the hospital and the medical students to oversee their care. So this model doesn't exactly exist all over. It's in a lot of practices, but like I said, in a few years, it probably won't exist. But it was really cool for me because I got to still be engaged with med students and residents and still be in the hospital, but also work in my private practice primarily. So when I was on service as the hospitalist, I would basically take every morning before clinic, go to the hospital, see all the new babies, see any patients that were in the hospital, round on them with the resident team, work with the residents to make a plan for the day, and then sort of organize with specialists if needed. So that was sort of the typical day. So in the office and then also in the hospital. So this is a typical week in private practice, okay? So a little hard here. Okay, so basically every morning I would go in, like I said, we would do hospital rounds before. From 8 to 12, I would see patients and then do phone calls in between. From 12 to 12:30, I would catch up, eat lunch, do more phone calls. In the afternoon, started at 1, I would follow up with the residents of the team on. I would do more patient care, so I would see patients until about 5, and then I would sit down to do phone calls. One evening every week, I would be one of the 2 attendings who was in the office to do evening hours. So patients who came in who couldn't be seen during the day, who were sick, who needed to come in from 5 o'clock to 8 o'clock, I would see those patients, and then I would do phone calls afterward. So basically, that was sort of the bulk of my life in private practice. Once every week, we would alternate taking call, and I'll go into what that means. And then one weekend every week, we would work in the office because our clinic was open on the weekends as well. Okay, so when I call as an attending in private practice, it was all by phone, so I didn't tend to go into the office for any reason. From 5 o'clock p.m. till 8 o'clock a.m., any question that our patients had, they would call this like after hours line, and it would go through to my phone, and I would answer any question the parents had. So basically, from 5 p.m. to 8 o'clock a.m., I would take on average 100 to 120 calls a night with patients, and I would talk them through their Tylenol dosage, things like, their baby was breathing funny. What could they do to help them at home? How would we figure out if they needed to go to the emergency room? If a baby had fallen, if they had swallowed something they weren't supposed to, if they had a rash. And a lot of times it's just reassurance. They had a new baby and they wanted to just make sure they were feeding okay. And then every now and then we'd have a triage nurse to sort of help us with those calls if they got to be too much. And they would ask for more higher level care. So if they needed to send a patient to the emergency room, if there was a patient in the hospital that needed our attention, if there was a newborn who had been delivered who was having issues, we would help to coordinate their care from phone. And then as far as teaching and administration, so in terms of teaching, most private practices don't do a lot of teaching with residents, and it just has to do with their contracts with different hospitals. So we would work mostly in our office with medical students. Move and see this poll. Yeah, exactly. So it is definitely possible. A lot of practices do it. Sorry, I saw the poll and it threw me. So what we would do with the medical students, which I loved, I was in charge of it and I loved it. So we had medical students from UVA, from VCU, and from Georgetown who would rotate through and they would shadow us. So kind of what you all had probably imagined doing this year, we would do it. We would have them come in to see patients with us. They would do little basic procedures. They would check vitals. They would listen, they would work on taking a history from patients, doing exams, figuring out plans. For me, because we were also able to partner with those hospitals, they often would take calls about new babies and learn about how to triage things, what things you look for red flags. So it was really fun. And then in terms of administration, like I said, I sort of touched on it a little bit already, but we did a lot of paperwork. There's a lot of paperwork when kids come into the office. So there's a lot with school and insurance, a lot of follow-up patient calls, a lot of calls with insurance company. We did a lot of student evaluations and figuring out sort of how to guide them for their next rotations. RVU data is basically in private practice much more important. All physicians do it, but in private practice, you essentially at times basically have to look at how productive you're being, so how many patients you're seeing a session, and that factors into the office's stability and well-being and financial compensation. Okay. And then charting, so finishing all the charts that we maybe hadn't gotten to do from earlier, looking at lab results and things like that. So that was life in private practice. Why don't we take a little quick break and then we can just, any questions that you have, I can answer for you. Does that sound okay, Yasmin, Lana?
Yes. So
Okay, cool.
we've had a couple of questions that we'll get to. There's actually a really interesting comment. One of our attendees actually went to Capital Area Pediatrics, and
as a kid?
Yes, and she said that that's what inspired her to be a pediatrician. So that was pretty cool.
Oh my gosh, that's amazing. That's so cool.
I think
that makes me so happy. That's very
one of the common questions we had was, did you have any input into like the business side of the private practice, or was that handled by like office managers, medical assistants, things like that?
Yeah, it's a great question. So mostly in terms of like the financial structure of the practice, that was sort of managed by our lead physician at our office. And then the CEO, we had 8 different offices in the practice around the state. So they kind of managed the financial model, but I would say that every quarter we gave input as the providers into the work that we were doing and how many patients we were realistically able to see, and if we could adjust time for patients or figure out ways to bill differently. So if someone had like a mental health problem, I would spend a lot of time talking with them about that, but I might not be able to bill it in a traditional way. So our feedback from the clinical standpoint would often help to fuel the way that they then worked with the insurance companies for reimbursement. Does that make sense?
Yes, thank you for clarifying.
Yeah, sure. And then I'll touch on it a little bit too when I talk about research as well.
Perfect. I think another question that we had was your experience working with like PAs, NPs, if you work with them a lot, if that's common in pediatrics, and kind of what their role is in your care.
Yeah, so I work with them a bunch. So I would say actually physician assistants in both DC, Virginia, and here, I haven't worked with them as much. And I think that has to do with their licensing and their privileges at different hospitals. But nurse practitioners, all the time. I love them. They've learned a ton from them. I think they're incredibly, incredibly proficient and really smart at what they do and bring like a really nice perspective to patient care. So at our office in the private practice, there were 8 providers, 2 were nurse practitioners, and both of those nurse practitioners were actually IBCLCs or lactation consultants as well. So they were incredibly helpful with newborns. They would actually partner their newborn visits with lactation help. And so often if I had a patient that I was seeing and I said, I really feel like they need some more breastfeeding support, I would have them block into the nurse practitioner schedule for a couple of visits in the beginning. So in terms of role, they were very much exactly like we are. Like they practice very similarly to us. They, in DC, they had to get signed off on if they did a certain kind of procedure, or if they prescribe controlled substances. So like if they were seeing kids with attention issues or ADHD, they had to get signed off on those. So they tended to not follow complex kids with mental health issues as much. Here at CHOP, I'll talk about it, we have 50 providers in my office and 12 of them are nurse practitioners. Again, we don't have PAs. I think it must be about the licensing. It must be some reason for that. But they do here exactly what we do. And they don't have to get signed off on anything except like every now and again, like an insurance company will require a co-signature. I love working with them. I think that they, like I said, have a really interesting perspective and they're really detail focused, which I love. And I'll talk about why.
Great. I guess we'll do one more question.
Yeah.
One that was asking about reimbursements in pediatrics, if you know anything about that. Apparently there's a little bit of an issue with it, some negativity around it. If you could speak on that, if you've had any.
Sure. Is the question about reimbursement for providers or reimbursement like for the practice as a whole, or both maybe, if they haven't specified that? Okay.
It was not clarified, but maybe it will be.
Yeah. Let's see.
They said for they private messaged and said for providers.
For providers. So it's a great question. So I think that as you're thinking about careers, it's so important to think about that. I love when people ask that question because we don't really think about it that much, right? Like you're so busy getting through medical school and like figuring out all that entails. So I think in terms of the specialties, if you look all around at every specialty, pediatrics and family medicine tend to be the most poorly reimbursed of every specialty. And by specialty, I mean like medicine, family medicine, OBGYN, things like that. The specialists in pediatric tend to be reimbursed at a higher rate than general pediatricians. And you're right, it's a source of a lot of negativity in a lot of places, right? Because it's hard. You work really hard in primary care and in general pediatrics. You see kids, you're often the first line. So what many people have found during this COVID time is that really primary care and ER folks are seeing the most intense volume of kids who are sick. So there's a lot of negativity around it for sure. And there's a lot of burnout with people in primary care in general, not just pediatricians, but internists, you know, anyone sort of along that spectrum. But I think that there are increasingly over time, and actually a lot more this year, I think there's going to be an opportunity to really have feedback into the things that occupy your time and finding additional ways to bill for them in a way that will eventually be reflected, not just in the reimbursement of wherever you work, but for you. So a lot of places have started doing telehealth for a variety of concerns. And I don't love it for everything, but I love it for things like mental health. I think it's really, really helpful. And I think it provides a real needed service. And there's a lot more positivity around reimbursement for things like that. And also reimbursement for quality of care rather than quantity of care. So there have been a lot of changes in the federal legislation that I think will now be enacted probably in the next couple of years to help primary care doctors sort of feel like the work they're doing gets reimbursed at a rate that's like appropriate for the effort they put in.
Great, thank you. I think we can move on and then questions.
Yeah, that sounds great. And any follow-up questions, please just send me and I'm happy to answer them. Okay. So when I was in medical school in residency, I like loved the idea of doing research, but I wasn't like a bench researcher. I wanted to sort of look at patients and figure out what would help them. And figure out ways to like use data to help them better in their lives. And I was really interested in early childhood development, so the first 3 years of life, and what mental health in those times for moms and for kids really looked like. So I had a great mentor in residency, and he was a pediatrician and a child psychiatrist, and he was amazing. And he basically helped me to craft together a lot of clinical research. So in residency, I published a few times with him in Pediatrics and a couple other journals to look at ways that people could start screening more kids in a more effective way for emotional challenges, and also new moms for postpartum depression. And I loved it. And I was a little nervous when I went into private practice that I wouldn't get the chance to sort of do that again. But there was opportunity. It just looked a little different than sort of what I had imagined and than what I do now. So there was a lot of opportunity. And I say this to all med students because I think it's important. There's always opportunity for research and for anything extra that you're looking to do. It's just about finding ways that work in your system. Apologies here. Okay, sorry. So in private practice, a lot of the research that providers did centered around quality improvement projects. So ways to look at data from, you know, how many kids were getting vaccinated with the flu shot, or how many kids were getting the HPV shot, and looking at ways to translate that data into opportunities to improve workflow, so to improve the quality of care. And that's a way that private practices, especially public as well, but the private practices especially, can get reimbursed and can get funded for additional research, or can help with provider reimbursement. So like if a pediatrics practice is getting, you know, 80% of their kids vaccinated for HPV, that's incredibly accomplished for them, and there are ways to get reimbursed. So the research was driven much more by quality improvement. So I had mentioned telehealth a little bit before. So because I focused on emotional health and mental health in kids, I launched sort of our telehealth practice and workflow to help address parents' needs, so that they didn't have to bring their kids in necessarily every single time they were worried about anxiety or attention issues, but that we could use telehealth to partner with clinical care. The other thing that a lot of providers did was to work on clinical committees. So either partnered with our local hospital, so I know of a Fairfax or Children's Hospital, to help to give a primary care perspective on simple things like, you know, if I saw a kid with asthma, how can I help to better the workflow in my practice, so that by the time I have to send them to the emergency room, I've done all the things that the specialist would have done, so that they're really teed up to get their optimal care there. And then, you know, a lot of the providers worked on like case reports from interesting patients, and they would submit it to journals as a primary care pediatrician in the private care setting. So that was something that we worked on in terms of research in the office. So there is a lot of opportunity for things like that. Okay, so let's move on to where I work now. So like I said, I moved about 3.5 years ago, and my husband works at Penn, and I had grown up around here and loved it. And so got this incredible opportunity to work at the Children's Hospital of Philadelphia, which I love. It's one of, you know, obviously it's an incredible institution. It's one of the best in the whole world. And I work at a place called Carabots. It's the biggest primary care clinic in the whole country. We have more than 30,000 patients now, and it's just a few blocks away from the main hospital. It is a huge building that was designed with the idea in mind that it would bring the best specialists from the Children's Hospital, as well as primary care pediatricians in to serve people who are underserved. So we work in West Philadelphia. It's an incredibly urban area. Our patients are very underserved. 93% of them are on public insurance. And it's incredible. We have 42 providers, a lot of nurse practitioners. We have 50 plus staff members, people who man the phones, who do triage, who do all of our front desk work, and are incredible. So to compare it to my private practice days, I wanted to kind of give you all a sense of this. So first of all, I get a few more minutes for each appointment. And when I describe it like 15, 30 minutes, it really sounds like nothing, but it's unfortunately sort of the standard of care these days. But I see 6 to 12 patients in a day. So our hours are a little bit abbreviated because they build in time for more complex patients, for patients who have more psychosocial needs, for patients who might need to follow up with specialists or need a social worker. We see all patients. So if they're late, if they're an hour or 2 hours late, we do our best to see them to, within our capabilities. A lot of patients don't show up, and we have a special team who reaches out to them to see if they need extra support or if there's a reason that they couldn't get there for their appointment, if there's anything we can do to help with transportation or support in the family or childcare. And we have a dedicated team of nurse care coordinators who help to manage complex kids and help them with follow-up appointments, a team of social workers, a team of community workers who goes out into the community to help patients learn about how they can set up their home in different ways to better their health. So let me give you an example. It's a really interesting blend, I think, of the private practice world of having really accessible care, but also to serve needs that are much more than just their basic medical needs. So that same patient I told you about, right? The patient whose mom had been worried about the crossing eye. I had a very similar patient a couple weeks ago. It was a 7-month-old, and the mom said, grandma has noticed that her eye is a little bit of a lazy eye, and she's only noticed it a couple times. I've never noticed it. But I'd love to see what you think. And so I examined this patient. They had a fairly normal exam. They didn't do the crossing of the eye for me, but with that history at that age, I thought it was important that they see an ophthalmologist. So at CHOP, everybody's on the same electronic medical system. All the specialists have one dedicated line. It's a phone line that any attending can call 24 hours a day and can get someone on the line to talk immediately about the patient to figure out how to help them. So I called the ophthalmology line. I talked to an attending ophthalmologist, and they said, "Are they in the office now? We have a million appointments. We're happy to see them." And I said, "Absolutely, like they have time right now." They didn't have a car. They had taken an Uber to the office. So we helped them to give them a cab voucher with our social workers. We got them right over to the hospital. We were able to get them seen within a few minutes, literally within a few minutes of their arrival. So within an hour of the time they had seen me, and get them into imaging for later that afternoon. So all in the same hospital. And the ophthalmologist sent me a note in our electronic medical record to give me updates. I let Dad know and the other family members who weren't able to go because of COVID restrictions to give them updates, also through our EMR. And within a day, they had found a small mass that we wouldn't probably have seen on exam necessarily, and they were able to get her into surgery within a day. So just really interesting coordinated care in a different way. Both patients got seen and got the care that they needed, but just having an infrastructure around it helped a lot, I think, to facilitate care for someone who wouldn't have probably been able to manage a lot of the tasks of calling to make appointments, getting to places with financial limitations over the next few weeks. Okay, so I'm going to tell you a little bit more about let me see, I just want to make sure I get a time. Okay, perfect. So a little bit about the week here. So I basically just highlighted some of the differences. So it's actually very similar in terms of I come in the morning, I see patients, I have a little more time with the patients, I do phone calls between patients. But here what they do is they build in one morning every week is an administrative session. So all the paperwork, all the phone calls I didn't get to make before, during, or after work during the days, I can just dedicate that morning every week to have it. And then one day every week in the afternoon, I have a med student with me, and they shadow me, they see their own patients, or we've now done sort of a combination of virtual and in-person, depending on just the guidelines of the week. But I have a med student with me, and I have fewer patients that I see that afternoon because we build in time for teaching. And then one afternoon a week, we have a thing that's called a float provider, which is a person who has no schedule and they help out the whole team. So if I notice that one of my colleagues is falling behind, I might grab a few patients off their schedule and see them to help sort of act as a pop-off valve. And then one afternoon a week, I just see sick visits. So I don't see regular checkups mixed in with sick visits. I just see sick visits, again, to act as sort of a pop-off valve to get people in who may have had trouble getting in for other appointments. And then one last afternoon a week, I work to precept residents. So the CHOP residents, we usually have 6 to 8 in any clinic, see patients on their own, and then I'm there attending. They talk through the patients with me. We go through any issues they have. I sign their charts. I look at the patients. We do some teaching. So it's interesting because the setup is basically the same in terms of patient care, phone calls, labs, administration, but by building in the time to the week, we're really able, I think, to better serve patient care by taking out the administrative time every day. And also it's nice to have dedicated time to teaching, which I missed and isn't really a part of private practice, you know, their priorities necessarily, they build it in, but here it's really a part of the mission and a part of the care. And here I take calls, so I take and call private practice once a week. Here I do it once every 8 weeks, and it's a phone service again from 5 p.m. to 8 a.m. But we have at CHOP a dedicated nurse triage pool. So there's 10 to 15 nurses who staff the line, and they only call me if they have gone through everything with the patient and the patient feels like they still want to talk to a provider, or they have to send them to the emergency room, or they have a patient of mine who, or of the practices, who's been admitted to the hospital and there are questions about them. So it's a much different approach to triage, but the volume is so much more, being at a bigger place, that they really have built it out from that. And then I talked a little bit about teaching and administration. So teaching there's much more, it's a central part of the mission of any academic center, right? They build in time for it. Your reimbursement as a provider includes the time you work with residents and students, and also how you evaluate them, what lectures you do with them, and help them with procedures and different things. And then in terms of administration, like I said, we build in time for paperwork, we build in time for follow-up calls, but all of the things that I mentioned before, there's a whole dedicated day to doing it, which really, really helps with reducing burnout, I think, as a pediatrician, as a primary care provider, because I have time to do it. I don't have to just do it like through the day or after the day ends, but it's a dedicated part of my work every day, and it's recognized and reimbursed in the same way. And so similarly, we talked a little bit about what I did and what people do for research in private practice. For here, research contributions are a central part of your career development. So at the end of every year, every provider gets an incentive or a bonus or whatever you call it. It's like a little extra. And part of that comes from the patients that you see, but also how you're advancing your career development through research and how you're advancing and contributing to the office as a whole. So the quality improvement projects that I had mentioned in private practice, it's the same exact things here in the academic world. And a lot of med students, a lot of residents work on those here too. Telehealth, vaccination rates, things like that. But also we do weekly conferences, and we're expected to attend to learn more about anything related to pediatrics, really. So we're lifelong learners, and we do clinical committees in the same way, but it's now part of our hospital. And so the clinical committees develop these clinical pathways so that there is a uniform way to evaluate a kid with asthma, whether you're in the outpatient setting, the ER setting, the inpatient hospital setting. And then there are a lot of case reports. The volume of the care is so much more just at this academic center that there is just an incredible amount to write on. And a lot of the residents take the lead on this, and we have med students help us. We have attendings who contribute, but it's really multidisciplinary as well. Let me talk about pre and post COVID, and I'm going to put that down, and then we can sort of go from there. And that's just basically the end here. I'm trying to get rid of this poll, guys. Sorry. So pre and post COVID. I don't know. I can't do that. Pre-COVID, basically the way that our days worked were we had well and sick visits all mixed in together. So I might have a morning where I came in and I said, oh, I have 3 checkups, and then I have 2 kids who were sick, and now I have 3 checkups again. And our medical assistants, our nurses, all did like testing. So if a kid needed a strep test, if a kid needed to be swabbed to see if they have flu, that was all done by supportive staff in our team. Post-COVID, we had to really reevaluate the way that we looked at our workflow in our practice. And so now every morning we all see well checkups. We close the office down, it's cleaned, it's disinfected. Everything is sort of reorganized for the afternoons and the evenings, which are all entirely sick visits. We screen really heavily for kids who have any signs or symptoms of COVID, or for family members who are exposed. We screen them when they call in to make an appointment. There's a pathway that we go through. There are screening questions that we ask. When they get to the appointment at the front desk, they go through a separate entrance and are asked a specific number of questions. And then they go to a specific hallway and they have a specific team of people that help. So one of us is sort of the COVID provider every afternoon, and we rotate. And we find that that helps to limit a lot of the exposure through the office. We don't catch everyone, but we do a pretty good job. And then, like I mentioned before, the nurses and the medical assistants used to do most of the testing. Now, if we're seeing a COVID kid, the doctor is the one who's taking their vital signs, who's doing the test for COVID, who's evaluating them, again, to try to limit exposure as much as we can. We're building out some changes to that to help expand the teams, but that's sort of what things have been like. At the place I work at, our COVID rate has been about, our total positivity rate's about 9.5%, which correlates pretty well with Philadelphia and sort of with the city as a whole. But we've been able to develop a COVID team at CHOP, the infectious disease teams, the rheumatologists, the cardiologists, they all kind of work on any kid with COVID, so that we have a whole registry of kids who've either been diagnosed with it, who've been exposed to it, and then we coordinate care for follow-up. So there's a lot of interesting things to work on this year. It's been an interesting year, to say the least. Okay. Could we maybe take a quick break and do some questions? Do we have any time for questions, or not yet?
Yeah, of course.
Cool.
Thank you for the COVID slide. It answered a bunch of questions that people.
Oh, good. Good. I'm glad.
Kind of going off of the COVID slide,
yeah.
There was a question asking, when do you think that kids will be vaccinated for COVID? If you see a need for it, and if you kind of know what that would look like.
Yeah, it's a great question. You know, they have just started some trials for kids who are 12 to 15 years old. And they have been completely, surprisingly to many, completely bombarded with patients who want to do it. Parents who want to have their kids, you know, do it. I'm just trying to move this a little bit. Kids who want to do it. So they're just starting those. I think realistically, the studies on kids that age, so that's, you know, it's pretty old, 12 to 15, so older kids. I think that will be through 2022. I would be surprised if we started looking at studies for kids under that before then. So most people tend to think that the trial studies will be complete in 2022. And the question is whether that will translate into recommending vaccination for kids 12 and up in that same year. If you would ask me 2 years ago if we would be recommending things so quickly after trial, I'd probably say never, no way. And I work with this guy called Paul Offit, who's at CHOP. He's like this, like incredible. He was in charge of the rotavirus vaccine. And so he's like, he's a lot on the news. He talks a lot about it. And he's always just like, we've gone at warp speed and that's good. You know, it's great. The data's there, so it's good. So I think by the end of 2022, we will start making recommendations for kids 12 and up. I don't know about kids 12 and lower. I just think it'll be a while. I think there's a total difference in the way you study those kids. If you look at other vaccine models, you know, it's very slow going for kids younger than that. There was a second part to the question, right? Do I think it's a good idea? Is that what?
Yeah, I think people are asking, like, do you think that even should be a thing? Are they affected enough? Would be vaccinated?
Yeah, it's a good question. So you're right. Kids tend to, by and large, not all of them, right, not be affected to the degree that adults are, or to the degree that young adults with chronic illness are. And you know, there's sort of back and forth on the data about infectivity in young kids. So whether or not they're clinically as sick, like, are they transmitting it more than older people or other people? And that data is pretty, you know, is pretty convincing that they are. So I think that by and large, vaccination for COVID is helpful. And I know that, you know, there's a lot of strong feelings about vaccines, and I know that we're early on and it's a new vaccine, but I think it's helpful. I think it will be one of the things that helps us get to the next phase of life right now. And so I think that, like any vaccine that I talk to my parents about, you know, at the end of the day, like, that parent has to decide for that kid if they think it's important for them, if they value it, if they think that it's something that that their child would benefit from. I personally would, like, if my kids were older, I would certainly do it. But, you know, I understand that there are risks and it's all personal choice. And I don't ever, with any vaccines, I don't decry anyone's feelings on that, because I think that every parent wants to do the best for their kids. Like, that's absolutely the way it is. They might have different opinions than me about it, but nobody's coming from a bad place when they think about vaccines. So that would be my thoughts on it.
Great. Thank you so much for answering that.
Sure.
A lot of people's questions.
I'm sure that's right. Yeah, it's on everyone's mind, right? It's a big deal. It's important. My patients, like, they'll come in, they'll be like, we want that vaccine, or we definitely don't want it. It's like they think it's out already. So it's, you know, it's on everyone's minds. I know.
Yeah, for sure. I guess kind of still sticking with the topic of COVID.
Yeah.
Is it true that it hits kids harder or less hard? Wrong words.
Yeah.
Than adults or elderly patients, or is it, like, hard to distinguish from the flu and stuff like that?
Yeah, it's a great question.
Are there any, like, benefits or cons to how it's arising in children?
Yeah, it's a great question. So by and large, if you look at the population as a whole, it affects kids. The severity of it tends to be less in kids than it is in older people or adults. And that's by and large. There are obviously exceptions to all of that. They don't know exactly why. They think it has a lot to do with natural immunity, with kids' immunity versus adult immunity. And we don't know exactly why. We're looking at why as a medical profession, I think, in whole. When I see a patient in the office with symptoms that look like COVID, so if they describe respiratory congestion, if they describe a fever, if they describe nausea or vomiting, you know, 2 years ago, that would have been the flu. You're right. Like, that might have been something that looked exactly like the flu. But now we always think of COVID, mostly because it's out there and they're exposed. So when I have seen kids with COVID, they tend to be not that sick. And that's kind of surprising to people. Like, they look like kids who are sick, who clearly have something going on. But by and large, anecdotally, they're not as sick as adults who present with the same symptoms. Now, kids with asthma, kids with other underlying conditions, those kids tend to have more complications, right? But they have complications by and large with anything, any kind of illness. So it, you know, yes and no. We test kids who kind of meet the criteria, and our criteria are pretty much developed by the best in the world, and we test a lot of kids for it. So we're often surprised. Sometimes people will say, I honestly would never have tested them in a different year. I would have just said, oh, they have a cold, but you know, now they need to go back to daycare and they have to get a test for that to return. Or now they have an elderly grandparent at home, so we have to test them to protect the people around them. And people pop up positive all the time. So I think it's probably something to do with kids' natural immunity, whether it's their gut immunity or their respiratory immunity that is protective. It'll be interesting to see in the next couple of years. It does look a lot like the flu. Yeah, it does. Because mostly you see fever and respiratory symptoms. The thing that's a little different is a lot more patients with COVID sometimes now are showing like GI symptoms. Like people are like, oh, we just thought he had a little stomach bug, and it turned out it was that. And that's a little less common with the flu. But you know, you look at both. I will tell you, I've done this now for more than a decade. I could count on one hand the number of kids I've seen with flu this year. It's just not the way it was before. So the fact that people are isolating, the fact that they're at home, has at least helped us to take some of the illness out of the normal winter months.
Great. I love to hear that.
Yeah.
Love to hear that. There's also a lot of questions about your opinions on telemedicine. Do you think it's going to stay with us, you know, post-COVID, all that, the disadvantages and advantages that you think?
I love that question. So I think it's a super, super important question. So I started our telehealth at our private practice for the 8 offices there. I started it from mental health. That was my focus with it. In the COVID era, it's just exploded, right? Because for months and months and months, doctors weren't able to see patients in the office. And so they resorted to, or relied on, I guess, you know, things that were available to them. And telemedicine presents a super interesting opportunity in that way. If you have a parent who can't drive to see you, or who is, you know, quarantining at home and they have a medical question, like, it's a really nice option to have. I don't think it's appropriate for everything. Okay, so I trained at a place that taught cura personalis. I don't know if anyone's heard this term, but it's basically you care for the whole patient, and there's value in placing your hands on a patient to examine them. So if a patient has like abdominal pain, there's not much I'm going to do for them in a telemedicine visit, because I want to examine their belly. I want to see what their urine test looks like. I want to look at their blood pressure, their vitals. You know, there are things where I think it is certainly being overused because of the circumstances that we're in. But I think that there are very specific individual situations where it's incredibly helpful. Rashes are one example. Like many, many, many rashes you can look at and know exactly what they are. Not every rash, and not rashes that are getting worse. And there's some value still to touching and feeling and making sure you see all of it in person. But, you know, you can get a lot of patient visits dealt with accurately over video conference for that. Things like, you know, feeding questions, but they're with a comfort that the baby is growing well in pediatrics, right? Like breastfeeding questions in the early days. There are some things that are super important. You want to see them in person, of course, to help them, but there are some things that are very much more focused on anticipatory guidance and figuring out what to expect. So I think I think there is a role for it. I think, like I said, for mental health, I think there is an incredible role for it. I think that you can talk a lot about kids' anxiety, depression, and, you know, attention issues. And it's kind of nice if you're a parent calling in for a kid with attention issues to not have to like wrangle your 3-year-old who's running around the room and talk about the attention issues they're having. Like, they can be comfortably at home. You can go in a different room. You can have someone else watch them. So I think in some ways it's actually like really works well. But I think it is here to stay. I think it's a model that has proven in this era that there is a need for some extension of it. I don't always think it's the best clinical tool. And I think that we have to be really cautious about using it in place of physical exam. Because like I said, I'm a very traditional, like, you have to see your patient in person, you have to listen to them, you have to connect with them, you have to examine them. But I think that it is definitely here to stay. And they have relaxed a lot of federal regulation for it in the last year, and those are all going to be continued, so I'm sure. that will continue.
Great, thank you. I guess we can keep going just a little more.
Yeah, I just have a little more. What time? Do you guys have a time? Sorry, I can't find one.
Yeah, or 10:05, 5 after the hour. So, and you're fine. We don't have to end at any specific time.
Okay, sorry. All right. So last thing. So last two things real quick. So I am like super new to social media. I am embarrassed to say I feel like 100 years old when I do it, but I wanted to start this thing that I call Resilient Rascals to talk about pediatrics, because like I said, I focus on early childhood development. So I focus on kids from birth to 3, their health and their emotional and social development. And I felt like in both private practice and in academic medicine, there were so many things I wanted to talk about. And I felt like I didn't have time to talk with my patients about simple things, big things about health, like, you know, really practical details. If you're a mom and you have a baby who's got a cough or cold, like these are the things you can do. Here's how to suction a baby. Here's how to do humidifiers. Like here's how to set them up. And I felt like there were a lot of details that I just didn't get to address in the quickness of every day. And so I wanted to find another outlet for a lot of the patients that I see and a lot of my old patients in DC who would ask me for advice, and to put it in this platform. So I started it on Instagram. I'm literally like super new to it. So I'm just starting, and I'm hoping to give practical tips that are based on my experience and also on my experience as a doctor and as a mom, for parents on like the specific details of how to manage health concerns, things people can do at home, things they should look for from a medical standpoint. And I've been really enjoying it. I'm super new to it. So all of you, please follow me. Let me know what you think. I love feedback. I'm happy for any feedback you have. And that's it. That's all I have. So that's why I'm excited, because it also gave me the chance to meet you all, and to connect with you all. So this is my quick summary for everybody. Just from what we talked about, there is something you can learn from every rotation. Okay, so be open. Imagine what you think your life will look like as a doctor. There are a lot of changes in medicine, but truthfully, there is all opportunity, and it's an amazing place to be, especially this year. You know, people talk about doctors and burnout and, you know, frustration, but think about how historic this year is for doctors and for healthcare providers. You know, you, even if you're virtual or not, are participating in and a part of and a member of a field that has changed the course of history. So it's an incredibly rewarding place to be, whether you're dealing with one patient or doing 1 million patients with public health. It's really amazing. So focus on the little details. Like I said, the things you can learn in every rotation. Think about how to be involved. And if you're not interested in traditional research, there are lots of ways to be involved, especially now with, you know, so much being online in terms of data collection. You can help in 1 million different ways. And then my last piece of advice, I guess, would just be to think about what kind of training you would like. Think about when you're looking at residencies as you get on, think about, do you imagine yourself, you know, having a little more time or a little less time with patients? Do you imagine yourself working closely with a big team or doing a lot on your own? And everyone's different. Everyone has their own feelings about what would make them feel the most fulfilled, and that can change over time. But thinking about it ahead of time will help you be an active decider of what comes in the future. And again, just being open, I think, will really help the whole way through. Be open, because things will surprise you that you never thought you'd be interested in. I never thought I'd be a person who did a lot of research. It just wasn't, I was interested in it, but I never thought it would be a core part of who I am. And now I really love it. I really love looking at it. I love working on it. I love submitting papers. It's just fun. So, and I never thought I'd be like a person on social media. So you never know, things change all the time. I'd love to get your questions, everyone. Thank you so much for this talk. I hope I haven't rambled on too much.
Thank you so much. And
sure.
This was amazing.
Really? Oh, you're so sweet.
Someone said that you can just really, in your voice, you can sense like the passion that you have for academics and
Oh, that's
education.
very
So thank you
sweet.
so much for
Oh, thank you. That warms my heart. That's very sweet.
We did get through a lot of the questions during the
Okay,
presentation.
good,
We'll
good.
do some that we didn't get through. If you guys have any questions that got lost, just type them up.
Yeah.
I think one of the questions a lot of people had was, as a pediatrician, did you go in knowing like how to deal with the parents? And is it a
Oh,
big
it's a
part of
great
dealing with
question.
like overbearing moms and dads
Yeah,
and
yeah,
guardians, how you
yeah.
kind of learn to deal with that if you didn't know before?
Yeah, that's a great question. It's like an amazing question. It's one that truthfully I hadn't thought a lot about before I did it. Honestly, I like kind of thought about it. I like saw parents, but I didn't realize that so much of my job would be counseling parents. Most of the visit is working with parents, right? So, I didn't anticipate it. I will say that it's been really interesting to work in two different populations because the types of questions I get, the types of parenting I see are totally different. In terms of overbearing, I love Washington, D.C. It has my heart, it's where I trained. But if you want to know about overbearing, lovely, amazing, dedicated parents, it's the suburbs of Washington, D.C. It's very privileged. It's wonderful parents who care. And I say it with love. They know I would say it to them truthfully. I'm like probably one of them. I don't know. So it's a great place to be. And then you look at, I deal with patients now who are really underserved and who part of my job in taking care of the kids is making sure that parents have enough financial assistance to buy food so that their kids can have nutrition. So I didn't anticipate it. It's been really great because I've learned a lot from a lot of the parents that I see. I've learned a lot about patients. I learn a lot about impatience. I learn a lot about the things that I think are important for kids to learn about. And then I became a mom myself and I suddenly was like, oh God, I understand why they're so overbearing because that's how I am now. And I'm like one of them. So I think it's a lot of your visits. And so I think it's a profession where, I imagine if you're an internist, if you have a spouse or a partner, it's a very similar interaction, but it's not just about your patient in front of you. It's about the family unit, and it's about figuring out how to be flexible in how you deliver information and figuring out how to meet people where they are. And that's half of medicine in general, is figuring out how to meet people where they are to get them to either do what's good for themselves or their family, or to get them to do what you need them to do in the moment.
Thank you for answering that. I think a lot of people
Sure.
they have to deal with parents.
Yeah. Yeah, it's a great question. I should have put that in there somewhere because I had never thought about it before, and I would definitely recommend it now. Yes.
I think another question that I saw pop up a couple times was, what direction do you see academic medicine or academic pediatrics going in with like technology? Because it was pretty different from private practice. So do you see it like expanding in any way?
I think so. Yeah. I mean, I think that, the thing about academic centers, they're not all the same. I obviously feel very privileged to be at a place that has an incredible resource pool. There are small academic centers as well, and they have just as much in different ways. But I think that, the electronic records, there's just such an advantage to having them in terms of coordinated care. And the whole thrust of medicine is coordinated care. It's finding different people in the team, whether it's a physician extender or a social worker or a nutritionist, finding ways to bring them into people's care. So I think it's going to expand for sure. I think, everyone now receives information as patients. On apps and by their phone. And so I think that that's where people get their information, right? Like they're on social media, they're on apps from their doctors to deliver it. That's just how we get information anymore. And so I think there's a tremendous incentive to expanding it. So I'm sure we'll see more of it.
Great. Thank you so much for
Sure.
that. We had a couple questions asking about just in general, was there anything that made you think this is what I want to do? I want to do pediatrics. And if you had any advice for people to find out if peds was for them or not.
Yeah. So I think that for me personally, I sort of came into med school and I liked everything. I was one of those students, like I kind of was like on surgery and I was like, oh, it's not totally my thing, but like I could see how you could be a plastic surgeon and it's amazing. And like I liked parts of it. I really liked medicine and peds. Like I liked the process of thinking through differential diagnoses. I liked the way that you could formulate detailed plans for patients that went beyond just like the immediate. And I love the idea of continuity. I was like a little, idealistic. I'm like still idealistic that like you can see the same patient forever and become the person in their family's life. So I personally liked that idea. I really liked peds compared with medicine because I felt like kids, just truthfully, by and large, they get better. They are naturally more resilient. Their bodies are more resilient. They have such tremendous potential in the first 3 years, especially of their life, but like throughout their life, to overcome trauma and to shift the way their bodies and minds work. And I think that that is incredibly hopeful. And for someone like me, I was like, I want to feel hopeful when I go in every day that like something will change. So I think that for me, I sort of whittled it down that way. I think if you don't really know what you want to do, the best thing to do is truthfully to talk to people, to get their impressions. A lot of people didn't come in thinking they wanted to do their specialty. You'll hear that from doctors all the time, that they started out thinking they wanted to be a surgeon and then they turned into an oncologist and they have no idea why, but this was it. And most people will tell you that it's one person that they talk to that made a difference in the way they experienced the whole thing. That's how I felt about mental health and early childhood development. I had a mentor and I was a resident, and he just changed the way I saw everything. And I felt like he saw something in me and helped me along my way. So you're not alone in this. It feels like you're alone this year, I know, for a lot of people, but you're not. We are all here. We are all happy to help. If you just follow me on Instagram and send me a DM. I am happy to always talk you through it. If you want to do like a shadowing session at my clinic, I'm happy to take you through. And most people feel that way. Like we're all searching for connection this year. I think it's just like the year, and we want to do something to help. So I think finding people and talking to as many people as you can. And if you feel like you click with someone or connect, like be very open. People want to help people who are training. Like even if it's feedback that they have, like that their experience isn't exactly what they imagined, it's all valuable.
Great. Thank you so much for that.
Sure.
I guess we'll wrap up with this last question. As we are, still in the midst of the pandemic, hopefully at the tail end of it, is there any last piece of advice you'd like to give us as pre-med students and post-bac and masters and all of that as we continue navigating through this very weird time?
Yeah, I think don't lose heart. I know it's been a long year, and I tell my patients that I think there are a million ways to find connection now, and we need you like more than ever. So it might feel like you're not a part of it because of the weirdness of the year, but don't lose heart. It will get better. And your experiences now, you will write about them one day when you're a resident looking for an attending job. You'll be like, I was in med school and this was the thing that I did. And you'll have all such different experiences than like I had when I was a med student. Like your story will continue and be totally different. And like I said, this is historic, and it's not in a good way historic always, but there are some beautiful things that have come of it. So don't lose heart. It will get better. Connect how you can connect. So find people that you can connect with, talk to people, whether it's social media, whether it's finding support in other ways. It'll get better, I promise.
Thank you so much, Dr. Gans.